All right, now we're going to assess Matt's musculoskeletal system. First thing I like to do is inspect, looking at all of the muscle groups, and the specific one we're going to start with is the hand and the fingers. We want to make sure that there's no obvious bruising, deformities, discoloration. Nothing looks like there's an injury or traumatic incident that had occurred. So now testing the range of motion, we have the patient hold their hands up and go ahead and flex your fingers upwards, extend them down. Do the same thing with your wrists now. Down. Now let's do the same thing over here. Flex your wrists up, or your fingers up. Good. Flex it down. All right, then up and down. And one common mistake too, a lot of people think strength is an assessment of musculoskeletal, but it's actually neurologic. So we won't have to test his grips and move on to his elbows. So with his forearms, go ahead and move up, bicep down, extend, up, down. And then we're going to supinate, which is like this, and go ahead and pronate, which is turn down. Same thing. Good. Over here. Yep. Supinate, pronate. Good. And then moving towards his shoulder. Before we go to the shoulder, we'll check for the radial deviation and ulnar deviation on his hands. Placing the hand here, we want to see the degree of measurement. If the, go ahead and turn your wrist inwards. If there is greater than 20 degrees towards the radial deviation, then there's obvious deformity or an injury. And then as far as the ulnar aspect, moving outwards, if it's between 50 and 60 or greater, then there's possible deviation there. We like to measure from left to right, so that side, I'll check this side too. Go ahead and turn in. Good, that's as far as you can go. All right, now outwards. Perfect. Moving on to the shoulder, the way we do that is by extending and flexing too. So extend it all the way up, yeah. Flex it all the way up, yeah. All right. Extending would go backwards, all the way back, put it behind your body. Good. All right, same thing over here. Up, 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 up. And down, 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 down. Good. And now, I also want to point out, before we have the patient do this, we're obviously looking for any signs of deformities, if there's any imbalances, or if the patient has unequal shoulder lengths, or if one arm is dragging or sagging lower than the other. It's an obvious sign of a deformity. So we always want to make sure that we look before we have the patient move and flex. Also, we want to palpate. We want to palpate inside the acromion process, make sure everything feels good. There's no mass or lesions, no deformities or bruises, and making sure that there's no fractures or dislocations. Any of this hurt? No. Good. Good. All right, and so after we're done assessing the arms, the hands, the wrists, the shoulders, we can now assess the spine. So have the patient stand. Go ahead and stand. All right. Oh. All right. Standing. Now, with the patient standing, we want to have them bend down, and you want to inspect the entire range of motion. So by having the patient bend down, we want to look at the curvature of the spine. We want to make sure that it's an equal shape. Making sure the concave, convex, and the color is all normal. And we want to keep in mind for, go ahead and lean back up. And go ahead and, yep, flex back there. Okay. And we want to make sure that if there's lordosis or kyphosis, the humpback, that we're aware of it as well. You can go ahead and sit down now. So now that we have assessed the spine and arms and upper body, now we can move down to the lower body. So the patient can go ahead and lie down. And we can assess the hips. One thing that I did want to point out too with the hips, you know, if there's ever one leg that's longer than the other, or it's externally rotated, it's a dead giveaway that while we're inspecting that there's a possible sign for a dislocated hip. So that's always something we need to assess before we start turning and twisting. With that being said, let's go ahead and abduce, which is going to bring the hip in. Does that hurt? No. Okay, and then we're going to abduce, which is out. Does that hurt? Mm. Okay, abduce is in. No. Okay, let's do the same thing over here. adducts outwards. Does that hurt?
Mm-hmm.
Okay. And there we go. Adduce. Good. All right. So with the hip, we always want to flex, extend, adduct, and adduce. But sometimes if the patient is not able to do those things and they're limited due to age, then you just have to be mindful of that. Lastly, we want to assess is the ankles and the legs. So by doing that, we can move down the leg, especially to the knee, and there's a vagus and the venal approach where you can assess the meniscus by putting pressure from the inside and pulling out. If that hurts the patient, then we're worried that there's a lateral tear or lateral injury to the meniscus. Does that hurt?
No.
Okay, let's try this side. Does that hurt?
Mm-hmm.
And then if we do the opposite, where we go in the outside and the inside, that's how we can test if the inner knee has an injury, deformity, or tear. Does that hurt?
No.
And so by applying reverse pressure, that's one way we can assess if there's a tear that we're worried about in the patient's knee. Moving down to the ankle, basically we want to flex up, extend down. All right, and then we want to go inner, external, external, inner, flex up, and extend down. Good. So as I had mentioned earlier too, the number one thing with assessing musculoskeletal system is not so much strength, but it's just the muscle function as far as how much range of motion the patient actually has. And that sums up the assessment.